Now, a haemothorax is where blood leaks into the pleural cavity and collects in the potential pleural space. A haemothorax. So in a haemothorax, the blood will leak into the pleural space, and of course it will go down wherever gravity is. So if the patient was sitting up, it would go down. If the patient was lying down, it would fall towards the back. So there's blood collecting in the pleural space. This could be caused by a lung laceration or damage to an intercostal vessel, for example, and the blood will accumulate. But the patient's still losing blood, even in a haemothorax where there's less than 1,500 mils of blood lost. That can still be quite a lot of blood, and the patient can be tachycardic if they've lost a litre of blood. But if there's a massive haemothorax, that's defined as there being more than 1,500 mils of blood. And that's important to know about. So if a chest drain's put in and there's 1,500 mils of blood, that's a massive haemothorax. And this is particularly likely to occur if there's penetrating injuries medial to the nipple lines in the middle, or medial to the scapulars in the back. In other words, the central part of the chest. Because this is where the large vessels are, the hilar vessels going in and out of the lung, through the lung hilum, where the pulmonary artery goes in and the pulmonary veins come out. And of course the major vessels of the mediastinum are also towards the centre of the chest. So very large volumes of blood can be lost in a massive haemothorax. And it's important to think about how much blood is being lost, because if it's what you might call an ordinary haemothorax, with maybe a litre or so of blood being lost, even though that's a lot of blood, it's probably going to stop bleeding on its own without a surgical intervention. But if there's larger volumes of blood, like 1.5 litres of blood or more being lost, or more than 1/3 of the patient's blood volume, then that is very likely going to require thoracotomy. So that's really time to start shouting for a thoracic surgeon to come in and save this patient's life. So how are we going to recognise that there's a large haemothorax? Well, the patient's lost a lot of blood, so clearly the patient's going to be shocked. They're going to be peripherally shut down, cold, tachycardic, hypotensive. And as well as that, there's going to be reduced breath sounds over the area of the haemothorax, because the lung is collapsed and the pleural space is filled up with blood, and that part of the lung is going to collapse. And that means you're not going to hear breath sounds over the area of haemothorax. And as well as that, when you percuss the affected area of the chest, do you remember we said that with a pneumothorax, you're going to have a hyporesonance because it's more hollow than normal. Well, clearly with a haemothorax, it's going to be more solid than normal. So you're going to get a dulled note on percussion. So shock associated with reduced breath sounds and dullness to percussion. So this patient's going to need a chest drain to evacuate the blood. It's important to evacuate the blood because we don't want it to clot, but it's particularly important to have a chest drain in so we can monitor the amount of blood being lost. So if it's 1 litre or so of blood, it's probably going to heal itself, or hemostasis will be established physiologically without surgical intervention. 1.5 litres of blood, we're probably going to need emergency preoperative care because it may well be the large vessels which are affected, requiring necessitating a thoracic surgeon. So chest drain first of all, then intravenous fluids, and we want to give quite large volumes of crystalloid intravenous fluids like normal saline or Hartmann's or Ringer's solution, one of these crystalloid solutions to increase the blood volume. But in a massive haemothorax, when the patient's lost a lot of blood, as well as replacing the fluid in the blood, we also need to start replacing the oxygen carrying capacity. And there probably won't be time to do full blood compatibility studies, so we can use type specific blood. So if the patient's B positive, we can give them B positive blood without doing the full blood type matching screen. There just might not be time for that type specific blood. Also bear in mind the possibility of collecting the patient's own blood for auto-transfusion if you've got the facility to do that. So remember, relatively small volumes of blood, 1500 mils or less, not that that's small, but if it's 1500 mils or less, then it's probably going to heal itself. Keep the patient warm, keep them still, and hopefully the bleeding will heal itself. Greater volumes of blood, 1500 mils or more, or if there's ongoing bleeding, if the patient's losing about 200 mils of blood per hour for several hours, again, that could be an indication for thoracotomy. And the patient's going to need a thoracic surgeon to open the chest and to close off the bleeding vessels.